And welcome. Thank you for viewing today's presentation on screening for food security in cardiac rehab settings. My name is Sarah Johnson, and I work at the Minnesota Department of Health in the Cardiovascular Health Unit. In my role, I support statewide initiatives that aim to address the prevention and management of cardiovascular disease, including projects related to cardiac rehab. And I'm thrilled to be joined with my co-presenters today. And I'll let them introduce themselves, and we'll start with Emma from Hunger Solutions.
Hello, my name is Emma Kiley. My pronouns are she, her, hers, and I am the SNAP RX coordinator at Hunger Solutions, Minnesota.
And my name is Whitney Quast. I am the supervisor of cardiac and pulmonary rehab at the University of Minnesota Medical Center, which is part of the mHealth Fairview Health System. And I am also on the board of directors for the Minnesota Association of Cardiovascular and Pulmonary Rehabilitation.
And my name is Paul Sicily. I'm a physical therapist. I am a rehab manager at Park Nicollet Methodist Hospital and working in cardiac and pulmonary rehab. And I'm also on the MNACVPR board of directors.
Great. Thank you all so much for being here and for introducing yourselves. I'll just walk through our agenda for today's presentation, and we'll start by briefly discussing the scope of food insecurity as well as the health and economic impacts of this issue. Then we'll transition to providing information about a possible solution that cardiac rehab programs can implement to address this issue among their patient populations. And then you'll actually get to hear from Paul and Whitney, who have implemented this initiative, and you can learn a little bit about how it's going for them, as well as some of the barriers and successes that they've experienced. And then we'll wrap up with a few resources that may be helpful to cardiac rehab programs or other healthcare professionals interested in learning more about this topic. So after the presentation, we hope that attendees will be able to describe how food insecurity impacts patient outcomes, understand the two-question food insecurity screening tool and how it can be implemented and used to identify patients at risk for food insecurity. We hope that folks will be able to describe the screening and intervening process in cardiac rehab settings, and then be able to identify community resources to support patients' food needs. So with that, I'll hand it over to Emma from Hunger Solutions to talk about the scope and impacts of food insecurity.
Great, thank you. So like Sarah mentioned, I will spend a few minutes kind of contextualizing the issue of food access, or food insecurity rather, in the context of health, economics, and the COVID-19 pandemic. So food insecurity means that an individual or a family has limited access to food, and they lack the money and other resources to acquire that food. Food insecurity can be seen within a wide range. On one end, you might see someone skipping meals or going without food for an extended period of time. And closer to the other end of the spectrum, you might see someone who can buy food, but due to limited funds, may buy food that isn't as healthy as they would like, or isn't culturally appropriate, or just isn't the food that they would prefer to eat. So in Minnesota, we know that 1 in 9 Minnesotans are food insecure. This ends up being about 500,000 people. And through the COVID-19 pandemic, this percentage and number certainly increased. In 2020, Minnesota food shelf visits went up 7%, which was a record high. And among seniors, this increase was over 30%, which just goes to show that there are certainly disparities among food access and Minnesotans. Next slide. So food insecure individuals are much more likely to experience obesity and diabetes, often due to the lack of access to nutrient-dense foods, as well as mental health concerns such as depression, anxiety, and stress. This is certainly a cyclical issue, as we know that folks often experience anxiety and stress about not knowing where their food might come from, and of course, all of the other stresses associated with living in poverty. And then, of course, the physical and bodily effects of not having enough food to eat or not having enough nutrient-dense or culturally appropriate food leads to increased depression, anxiety, and stress. And most important to our conversation today is that food insecurity is associated with higher risk of cardiovascular disease mortality among US adults. This was recently published in the Journal of the American Heart Association, and the findings really underscore the need for continued policy and systems level change aimed at reducing food insecurity rates, as well as the importance of screening for food insecurity where individuals are seeking care to prevent cardiovascular disease. We also know that 1 in 5 people who have had a heart attack will be readmitted for a second one within 5 years. And this also really confirms the need to focus on more upstream food access screening. Next slide. So we also know that food insecurity leads to higher healthcare costs, both for the healthcare system and for the individual. Food insecurity is not only associated with poor health outcomes, but like I said, is also associated with increased healthcare costs. And this is mostly due to the increased number of emergency department visits, inpatient hospitalizations, and prescription medication. And because of all of this, it has been demonstrated that food insecure individuals are more frequent users of the healthcare system. These costs certainly add up. It has been estimated that the effects of hunger costs Minnesotans nearly $1 billion annually in only direct medical expenses. And in addition to that, we know for most people, it is more expensive to be poor. Folks experiencing poverty often end up having to spend more money on their basic needs, especially as we see things like predatory loan and paycheck loan companies. A great food-related example of this is if you have a larger family, you might benefit from buying some of your food in bulk. This would save you money over the long term, but you would need that upfront capital to buy that larger amount of food. So for a family experiencing food insecurity or poverty, maybe living paycheck to paycheck, they likely cannot afford that larger upfront cost, and as a result will end up spending more money over that same period of time. So that's just one example of how folks who are food insecure and living in poverty often end up having to put more money towards their basic needs in the long run. Next slide. So my last point here is just to say that there have always been race, gender, and of course class disparities within systems of poverty and food insecurity. And the COVID-19 pandemic has really exacerbated these disparities. We see in the chart here that over just a couple of months of the pandemic, food insecurity among BIPOC or Black, Indigenous people of color was the highest. And this is especially important as we think about systems change, especially in a health setting where we're working to address some of that. And with that, I will turn it over to Whitney.
So what we as a state, primarily the Minnesota Department of Health and MNACVPR, have done to address this serious issue of food insecurity is that we rolled out a process for screening cardiac rehab patients and for referring them to hunger solutions. And so I'm going to tell you a little bit more about that. So MDH and MNACVPR identified some cardiac rehab programs at mHealth Fairview and Park Nicollet Methodist Hospital to pilot this process beginning in the fall of 2019. And so what these programs have done is used 2 validated screening questions to assess if food insecurity is an issue. So the first question is, within the past 12 months, we worried whether our food would run out before we got money to buy more, yes or no? And the second question is, within the past 12 months, the food we bought just didn't last and we didn't have enough money to get more, yes or no? So if a cardiac rehab patient answers yes to either of those 2 questions, then they are given the option to be referred to the Minnesota Food Helpline via Hunger Solutions. And so we would have the patient fill out a simple referral form, and then we would fax that over to Hunger Solutions that would contact the patient within 48 hours to offer them a variety of resources. And those can include everything from SNAP to WIC to school meal vouchers to food shelves that they might not know about, offering farmers markets and many other resources. Next slide. So research has shown that individuals who receive food support are less likely to be readmitted to the hospital because they're better able to follow nutrition recommendations from their care providers with those resources, and they have higher purchasing power if their basic needs are met. So the reasons that we thought it would be important to do this in cardiac rehab is that all of our patients obviously have had a heart event and have many other chronic conditions in many cases. Cardiac rehab is a long-term program, and we really try to look at the big picture of our patients' health, looking at nutrition, exercise, psychosocial, all those things that affect their health and their heart. And so it's a great opportunity to help them wherever there's a gap. And there are resources and multiple connecting points, such as dietitians, behavioral health therapists, and a lot of places that we can reach patients in their areas of need throughout cardiac rehab. And a lot of times after a patient has a serious health event, their perspective may have shifted. And so maybe patients have been offered resources in the past that have declined them for whatever reason, but they might be looking at things a little bit differently now after having a heart attack or heart surgery. And so it can be a really opportune time to offer them some resources that they might not know about or might have declined in the past. Next slide. And so some more details on how food insecurity ties into our program and patient goals is that nutrition is one of the 4 domains that we address directly in cardiac rehab. Psychosocial health is another domain, and if a patient is not psychosocially well, it's going to be really hard for them to succeed in any of the other domains that we're trying to address. If they're coming to rehab feeling hungry every day or not having their basic needs met at home, it's going to be really hard for them to comply and do the other things that we're recommending that they do to improve their health. Their success depends on coming regularly and exercising regularly. And so a lot of these patients have many basic unmet needs, such as transportation and whatnot. And so this is one way that we are able to address their need of food insecurity. So maybe they have more money to pay for transportation to get to rehab. And so it can impact their outcomes. So we still have found that these patients are less likely to complete the full program or are less likely to complete as many sessions as their food insecure counterparts, but it has been successful in improving their overall attendance. And so I'm going to go ahead and turn this over to Paul Spildy to share some stories from the field.
Thanks, Whitney. Just a few perspectives from our programs as we've started this program and have been doing it for a little while. So the first thing is, what what need does this this program address when food security is identified? And as Whitney mentioned, we hear the stories about patients who have to make choices about how they spend their money. And unfortunately, it's some necessities like housing or rent or paying bills or how they pay for their medication or transportation. Maybe it's a bus transportation, or maybe it's gas, and it's also food. And so, you know, to be able to give a patient resources to assist with food insecurity can help offset some of these other expenses and give them some help with paying for other basic needs. It also offers a sense of social support during their recovery. So just some added support that way financially and with resources for food. Some barriers that we encountered as we started this program, you know, it's sometimes hard when people are asked to give information to an outside group. They had a little bit of discomfort, or they were reluctant to give information. And so I think after we assured them that that it was going to a reputable organization like Hunger Solutions, and it was going to be giving them some resources and support, they didn't have to participate if they didn't want to. It seemed like they were more willing to give information. The other thing that we found is asking verbally the question of, do you have enough money to buy food, or are you afraid you're going to run out? We found that patients were more reluctant to give a verbal answer, and we transitioned to a paper form where they just circled a yes or no answer on the paper, and kind of outside of us sitting right there watching them. And we found that people were more willing to reply maybe in a more honest way that way. The other thing, I think, you know, it's hard for people to admit sometimes that they're having food insecurity. It's embarrassing, it hurts their pride. And we just wanted to reassure them that it was okay and that there was help available, even if it was for a short period of time. One thing that at times, maybe during this pandemic, and I know we talked about maybe overall numbers, but at times with more resources from the government, there were fewer patients being screened positively because of the support from financial programs that were kind of strong during the pandemic, and we know that those are kind of going away now. So we probably will be seeing numbers increase as time goes on. And then the last barrier, as we filled out forms just between the two hospitals, making sure we were providing consistent information to Hunger Solutions so that we were getting accurate information back, was one other thing we needed to work on, and did figure that out in the end. Next slide. So how has this program helped to address the problem? So most people who positively screened to food insecurity agreed to a referral to Hunger Solutions. As Whitney mentioned, at both Fairview and Park Nicollet, we see patients are averaging about 24 sessions of cardiac rehab, maybe a little bit more in the past couple of years. That was a number from 2019. But we do know that people who are food insecure tend to complete about half as many sessions. And we know there are barriers other than food insecurity for people attending, both from time away from work and co-pays and transportation and parking costs. And so that's something we need to continue to look at, is how do we reduce barriers for people coming to a long-term program, because we know that it is valuable for their health and their improvement after a heart event. Some other things that have happened in the organization so far at Park Nicollet and Health Partners, we have used this intervention at many of the clinic sites and plan to expand it to all of our rehab locations. And then M Health Fairview has expanded the intervention to clinics and to all cardiac and pulmonary rehab sites within their organization, which is great to get this out to more people. And then just one patient perspective. A quote from a Park Nicollet patient: "This program provided me much needed encouragement and support. To be given some resources as for food options really made me feel like they cared about me as a person, not just a number." And I think if we can show that we care about these people, the whole person, and not just a diagnosis, I think it builds trust, it gives people hope, and hopefully improves the chance of attending cardiac rehab to improve their heart health and their overall function. So I will turn it back to Sarah, I believe.
Great. Thank you, Paul. Really appreciate you sharing that patient perspective there and how this intervention can really address the whole patient. So we'll round out today's presentation with a list of resources that may be of interest to you or your organization. We've highlighted just a few. There are many, but the American Heart Association has information about food insecurity as well as resources for healthy eating. And then, of course, our partners at Hunger Solutions have a lot of great information and programs that support this issue. The SNAP RX program, which is the program that was implemented by Park Nicollet and M Health Fairview, really aims to strengthen the connection between healthcare and hunger relief organizations. And in addition, Hunger Solutions supports the Minnesota Food Helpline, which was mentioned during the presentation. And when folks call, each caller receives an assessment and they're provided with solutions to meet their food needs. And this is really great for folks to see if they qualify for the Supplemental Nutrition Assistance Program, or SNAP, or other resources in their area or in their community. And then the last resource that I'll mention, which is also available on the Hunger Solutions website, is the Find Help map. And this map allows users to search for food resources near them. And some of those resources include the ones listed there on the screen: food shelves, farmers markets, locations where free meals may be available, discount grocery stores, things like that. So with that, I'll bring our presentation to a close. Thank you so much for your time and attention today. We hope that you found the information helpful. And I just want to give a big thanks to our co-presenters, Emma, Whitney, and Paul. Really appreciate you sharing your insights and experiences, and for the incredibly important work that you guys do every day. Really appreciate it. So thanks, everybody. Take care and be well.